As Dr. Goodwani mentioned, we have Adrienne Markworth here, who is the founder and executive director of Leah's Pantry. And we are so lucky that she's local to us. She's from San Diego, but she really is, has become this thought leader on trauma-informed nutrition security around the country. And we are lucky to have her here to be able to talk to us a little bit about this program, Leah's Pantry, and how it came about and what it does for people. So, Adrienne?
Hi, good morning. I'm going to share my screen because I'm going to do complicated stuff, maybe.
Or
and okay, can everyone see my screen? I can no longer see any of you.
Yes.
Okay, I just lost all the video. So good morning, everyone. Thank you so much to everybody for inviting me here today. Let's see. Here we go. And I've been working with the San Diego County Obesity Initiative for a few years, and it's just been such a real pleasure to be part of the healthcare domain that's been putting this event together. But it's Saturday morning, and everyone's probably had a long week, and it's been a long couple of years. And so I think we're going to be talking about some interesting stuff today, but also a little heavy. And so I just kind of want to start with a really quick mindfulness activity to get everybody in the room, especially if you're working from home and members of your family are having their normal Saturday morning, which may be slightly distracting. So if everybody just wants to kind of take a deep breath, roll up the shoulders, maybe stretch a little bit, just look around the room, wherever you are, and just identify 5 objects that you can see. Anything. And then I want you to touch something. So find 4 things you can touch, coffee cup, your dorky headset, your mouse, whatever it is, 4 things that you can touch. Sometimes I just touch my own hands, which helps me get grounded. What's going on in your background? Can you hear, 3 things? Can you hear the coffee maker going, or kids getting ready for soccer, or whatever it is happening in your house? And then 2 things that you can smell. Can you smell 2 things in the air? Get that smelling sense. And then last, see if you can taste something in your mouth, anything left over from breakfast or maybe the coffee you're sipping. Okay, so it's important to get kind of physically, mentally, emotionally, spiritually, like kind of in the room when we really want to dive into some of these difficult issues. I'm going to put something in the chat right now, and it's okay, can you all see this question? Somebody just needs to tell me real quick in the chat that you can see the big question. Okay.
Yep, sure.
So if you want to go to menti.com and use the code 26270940. So give everyone a second to do that. It actually works great on your phone. So if you've got your phone nearby. And the first thing I want to ask you to do is answer the question, how do you feel when talking to patients about their weight and dietary choices? So think about how this feels to you. Just 1-word answers. You can actually answer 3 times. And we'll start to see these kind of pop up into a word cloud. Okay, so we're seeing a lot of feelings here, and they're different. Some are positive, some are negative. Uncomfortable. Wow, uncomfortable is really jumping to the front. Anxious, frustrated, uncomfortable, drained. Right, this is hard to watch for me right now, right? Like I'm having kind of all the feels as I'm thinking about all of you in these moments, having these feelings with patience, doing the work that you're trained to do, doing the work that you love, and all this stuff, coming up. Thank you so much for sharing. This is kind of vulnerable stuff. Okay, judgmental, intrusive, and then also support and goal and critical, right? Starting point, motivated, right? So we have a lot of stuff here. That's similar. I mean, that's kind of on both sides. Okay, so I'm starting with your feelings first, right? Because I think it's important to get all this stuff on the table. I think in order to bring compassion and connection to this topic, we have to recenter our work. But ultimately, a trauma-informed approach will recenter the patient experience, but that's really not where we have to go first. Where we have to go first is acknowledging our own experience, self-reflecting, and that's the first step, I think, in really deeply empathizing with the experience of others. So over the course of the day, please hold this discomfort with you on this topic, right? Your own personal struggles with weight or health, close to the surface, really be acknowledging and feeling that your feelings, your reflections are critical in this work, and they're valid. And actually as important as any new strategies or skills that you might be exposed to today, because it is bringing that authentic self that allows us to develop compassionate relationships with others that are grounded in empathy, which then of course allows us to be a part of a healing community that we're all called to do in this work, whether me as someone who works in community nutrition and food security, or you all working in a medical setting. It's hard to pinpoint the beginning of what's referred to as the obesity epidemic, but we do know that in 1999, a CDC press release and then 2 articles and an editorial that were published in the Journal of the American Medical Association, and they highlighted a couple things. First, highlighting this precipitous rise in overweight and obesity rates during the 1990s. Also calling out obesity as an epidemic and laying out kind of an eat less, move more path to change. Also, really inviting physicians to start counseling their patients to lose weight. And then last, a discussion of the connection between public policy, calorie consumption, and physical activity. So, already we're looking at some of these social determinants, back in the late 90s. Now, for the past 15 years, I have been doing my part to respond to the CDC's call to action and working on a variety of public and community health initiatives, many funded by the $464 million SNAP-Ed program, which we call in California, CalFresh Healthy Living. And I've had the ability to train thousands of nutrition professionals. We've authored various curricula used throughout the country. I've taught just so many cooking classes, so much fun. And also participated in a lot of upstream efforts. For example, food sourcing policies at food banks or something like that. I've sat on a lot of task forces and work groups and collaboratives, really working together to support food environments that do make room for healthy choices, or dietary behaviors that are prioritizing fruits and vegetables, healthy procurement policies to support local farmers, and have done some food system work, not only in California, but also in Indiana and New York State. But, more than any of that, I've really had the privilege of listening deeply to people talk about their complicated and often frustrating relationship with food, with cooking, their weight, their health, their children's eating habits, their partner's eating habits, their struggles with chronic disease. And it's been those conversations combined with the research around toxic stress that we just heard about that have really led our organization to a different approach to nutrition and dietary health. And so we'll get to that in a few minutes. But first, let's provide a little bit of quick historical context for what happened after those 1999 journal articles in the world of community nutrition. So initially, this national attention that highlighted childhood obesity as a problem of epidemic proportions, as well as linking obesity to health issues, led to a lot of investment, public, philanthropic, private, into educational interventions. If people don't know how to eat well, then they won't. If they don't know how to cook, they'll lean on processed and packaged foods. learning to budget, reading labels, and switching, say, like white rice to brown rice will help turn the tide of poor health. And this is very much in line with an individual responsibility frame. So focusing on encouraging healthy individual choices but the implication here is that if you are suffering from poor health, then it sort of also fell squarely on your shoulders because, you should know better. So this theory of change here that is at play is an energy balance model of weight management, right? Move more to burn more calories and then eat less so that you have fewer calories to burn. But I think the science of weight loss is a little bit more complicated than calories in and calories out. And metabolism is tricky, and weight loss essentially is a national pastime. So then we can enter in the social determinants of health. So when we're thinking about this, we can think about the environments where people live, work, play, and learn. And in areas with social disadvantage, those settings tend to look different than in more affluent areas. And obesity rates do correlate to income. Groups with lower income tend to face higher rates of obesity. So then complementing individual nutrition education programs were programs not really intended to directly engage individuals, but instead working on the settings themselves. So these interventions in many cases still do rely on an energy balance model, but in the world of community nutrition, it felt like a big leap forward when programming moved from group classes to these policy systems and environmental changes. So for a while, these social determinants of change or of health really, really seemed like the holy grail of obesity and chronic disease prevention. We knew obviously that when schools served unhealthy and terrible food or parks were unsafe, it was simply not possible for individuals to exercise or eat well. So this was a critical acknowledgement that individual choices were not made in a vacuum, but still the overall aim was for individuals to make healthier choices, and this was just one way to make those choices easier. In the federal SNAP Ed program, these types of interventions were allowable beginning not until 2014. So by 2016, almost every state reported an intention to include at least one. And actually this data just came out this month in the Journal of Nutrition Education and Behavior. And I've seen this firsthand. Many counties in California now spend almost half their SNAP Ed dollars on PSE interventions that complement their nutrition workshops. And these interventions include efforts to change food environments, such as school lunchrooms, food pantries, hospital cafeterias, senior lunch sites, farmers markets, remodeled grocery store checkout lines, but again, the results are mixed, and PSEs are very hard to evaluate. Leah's Pantry, which is my organization, collects a lot of data on the PSA interventions that we run, and we can definitely document improvements, for example, in food pantry settings, and increase, say, in the inventory of fresh vegetables distributed. But tracing that impact directly to the pantry clients is a little bit elusive. And other interventions report challenges, right? Farmers markets don't always take off, even when they're put into so-called food deserts with clever incentives to drive demand. School lunches that align with healthier standards are still plagued by waste and poor student reviews. So we've delivered the clear messages, we've helped to change the environments to become healthier, but Americans still face alarming chronic disease rates and don't come close to a passing grade in any healthy eating category. So despite multi-level interventions to make the easy choice the healthy choice, to eat less, move more, we have not seen a meaningful decrease in obesity rates over the past 20 years. Nationally, we've seen a 45% increase in adolescent obesity since 2001. And COVID, of course, has not helped attempts to reverse this curve. And further, there's not much difference between dietary quality across economic groups. So the promise of social determinants, largely predicated on the idea that people in disadvantaged environments were more likely to eat poorly, doesn't actually have a ton of data on its side either. People in higher economic brackets only eat about 4 percentage points better than people in lower ones. Yet they do face significantly lower obesity and chronic disease rates, sort of stressing this tenuous connection in some cases between dietary quality and obesity rates. So the science of weight loss and chronic disease prevention is complicated, but the educational model of if you know better, do better isn't necessarily effective. And while social determinant interventions have promise and energy, they haven't quite delivered in the way that we've hoped either. So, can we revisit this theory of change? So I'm starting with this because it's part of this health ecosystem, that brings us here today. And it's not just doctors, of course, that need to think beyond BMI. We all need this conference. Patients hear dietary advice from a lot of sources. Medical practitioners, of course, but then community nutrition, social media, posters on walls, PSAs on billboards, but pieces of this puzzle are still missing. So in an effort to simplify, provide clear direction, cut through the noise, we may have narrowed the frame around healthy eating, obesity, and chronic disease a little bit too much. So to move beyond BMI, we need to connect our individual actions to cross-section systems of learning and collaboration. And the patient, not the message, needs to be in the center of these efforts. So one example of this oversimplification is just to consider this link between weight and health. And let's consider the role of weight stigma. So to get a sense of how this looks from the patient perspective, let's go on a quick trip to the world of TikTok, which is where my teenagers live, like about half the time. So when I told them about this conference, they knew just what I was talking about. And my daughter helped me immediately find this video. So I'm going to show it right now, but first I'm going to stop sharing and make sure that I've shared the right way. Yes, okay. Let's see if this is going to work for me or not.
And the soda, you don't eat none of those? A liar. Okay, so what's this? Carrot. What's this? Apple. Don't worry, honey, don't start crying. I'll write it down for you. You won't forget. Okay, so mom, she's going to be drinking 12 gallons a day. And then a slice of baby carrot, just a slice. And she'll be okay, okay? I'll be watching you. Hi, Mom. Hi, Emily. Emily, you've gotten so big.
Okay, so in the world of trauma-informed care, we talk a lot about leveling power dynamics, and people feel really comfortable speaking. Oh, thank you. Yeah. There we go. Okay, need all the help I can get this morning. So on this platform, TikTok, which, grown-ups like me often like to make fun of, I think if you cut through the noise and kind of the dance videos and do a little bit of deep diving, you can actually get a very clear sense of what people think and feel. I don't know what your reaction to this video was, and I know I kind of played it a little bit out of order, but I felt kind of a mixture of amusement because she did a great job of playing a pediatrician in kind of a Saturday Night Live kind of way, but also this deep sadness, right? That this woman who made this video did not see her pediatrician as a compassionate partner in her health of her family. And the pediatrician who inspired this video certainly did not spend many years training to become a TikTok parody. So when we contrast this type of a video with the word cloud that we just looked at, and maybe I can kind of pull that up again. This is a very interesting situation, right? Where we have however many practitioners are on this call right now expressing very difficult emotions around talking about weight and dietary choices. But then we also have patients not feeling that at all, but just feeling the judgment, the oversimplification, and the lack of connection. So tough stuff. We have to respond differently than we have, in the past. I think as a society, our messages often place an overemphasis on individual behavior and responsibility. And public health certainly makes this mistake, of poorly translating the limited scope of population level research into recommendations for food behaviors. And the science of trauma and neurobiology shows that most health and social problems are not because of individuals, but because of the result of this complex interplay of biology, wiring, and our environment. And so many of our unexamined beliefs and messages about well-being or success have created unnecessary and damaging shame, stigma, and othering of people who suffer or struggle, which then makes it even harder for them to take care of their well-being. So how do we shift this? I mean, these negative attitudes towards obese and overweight persons are pervasive. Researchers have documented harmful weight-based stereotypes, such as the idea that overweight and obese individuals are lazy or weak-willed, unsuccessful, unintelligent, lack self-discipline, have poor willpower, are non-compliant. And these stereotypes really pave the way for this kind of stigma, prejudice, and discrimination against obese persons throughout society. The healthcare setting, no exception. And these researchers who look at weight stigma have also concluded that the weight stigma in itself is a threat to health, generates health disparities, and interferes with effective obesity intervention efforts. So that, that makes it something that we as professionals really need to work on. But it's often justified because of the belief that it may motivate individuals to adopt healthier behaviors. So are we guilty of this weight bias, against ourselves, against others? So if you Google Harvard Project Implicit Health, you can take a test to see the extent of your weight bias. Are you judgmental about yourself when it comes to your weight? If so, you're probably bringing weight bias into your practice. Implicit bias around weight is so common, but especially damaging when it lives in nutrition educators like me or healthcare practitioners, because we are in the business of talking with people, not just about their weight. I mean, in fact, sometimes we can avoid discussing weight, but their health, their eating habits, exercise levels, which is really often coded language for discussing weight. Since it's not really very enjoyable to talk about weight, we often talk about diet or exercise instead. So eating healthy in our culture is essentially a proxy for eating thin. In fact, the word healthy is often a proxy for the word thin. Conjure up images of a healthy person, and it's likely that your mind will be populated by thin and active people. So when I typed in healthy person to Google, this is what the hive mind came back with. Research suggests that weight is not in itself a marker of health. So in the case of type 2 diabetes, several studies presented evidence that among type 2 diabetics, underweight patients have the highest death risk. Lack of physical fitness, for example, can be more predictive of early death or cardiovascular health than weight. So overdoing the energy balance messaging can be harmful because physical activity is a benefit in its own right. But so often people's primary association with exercise is sort of calorie burning and misery. Not only do most of us associate healthy with thin, but we unconsciously assign other positive characteristics to thin people, right? Kind of the opposite of this weight bias, that just because you're thin means you're hardworking, intelligent, beautiful, maybe full of self-control and discipline. So folks carrying extra weight are then left with an exhausting burden of proving otherwise, that weight does not determine the value or worth of their person. So let's start to redraw these pervasive mental and cultural images of health. Weight is not the primary indicator of health. Furthermore, health includes having loving connection, joy, new experiences, and a sense of belonging. And you'll hear more about this in a couple of sessions when the HOPE project is discussed, and not just what we eat. So to borrow the title from this conference, let's get beyond BMI. I mean, aside from weight stigma and overweighting personal responsibility for health, some of our problems could just be statistical literacy. The first thing we learned in our high school statistics classes, that correlation does not imply causation, is also at play with our oversimplified theory of change. Just because obesity and poor health are correlated does not mean that there is always a causative relationship or that there aren't other important factors playing a role. So this is where a trauma-informed lens can provide some structure as we investigate further. So how can a trauma-informed approach help us reframe the relationship between health and weight? And how can a trauma-informed approach help us reframe food and exercise to be about more than maintaining a healthy weight while still seeking health and a reduction in chronic disease? All right, let's do another quick activity here. Okay, so take a minute and consider this image. And if you'd like to share, you can do so in the Mentimeter link. So what are the first things? Let's see if I can figure out how to get back to. Okay, hopefully that worked now. So what comes to mind when you see the Cheerios image? Too much milk. Had blueberries, bland colors, simple meal, childhood. Okay. Where's the sugar bowl? Okay, now we're getting somewhere. Saturday morning. Yep, not enough. Whole grains, half eaten, processed food, unbalanced. So after looking at the picture, you might have recalled how your bowl of Cheerios never met the aesthetic expectations promised on the box. Like, oh, this is bland. You might have recalled eating those Cheerios that made you feel more connected to American culture, right? As an immigrant child, we hear that a lot from refugee and immigrant children or adults who wanted to adopt these very American foods as part of their own acculturation. Or you might have fond memories of Saturday morning cartoons or maybe even the college dining hall. So if you were to spend some time considering your response further, you might have begun exploring aspects of your personal relationship to food and its meaning in your life. You might begin to recognize that food has a variety of meanings for you. While almost all of us at this conference are likely to place a high value on foods linked to health, you may equally value the social dimension of food as well. Or food might reflect your spiritual values. There could be times where food as a connection with others is actually more important to you than your moral beliefs about food. I have plenty of examples of this in my own life. While I'm often finicky about the quality of food I'm providing for my family, my teenagers have assured me that their friends will be happier if there's some snack food around when friends come over to hang out. And I want to get to know my kids' friends. So I've become a little bit more flexible, about what I'll buy when we're hosting at our house. So let's go back to Mentimeter again, and I want you to read. Let's see if I can do this quickly again. Getting good. Okay. So read the sentences on this slide and kind of say whether you strongly agree or strongly disagree with these particular statements. Meal can be a work of art. Food connects me with my culture. Nourishing my mind and body matters. Food feeds my soul. I care about the impact of my food choices on the world. Oh, there we go. That's pretty cool. See, for you data people out there, isn't Mentimeter fun? So yeah, we can see that there is differences between us, right? We all have different ideas about the meaning of food in our lives. So taking a trauma-informed approach to food means first recognizing that food is not just about filling our bellies and eating for health, but backing away from food as entirely transactional, right? I eat to feel full, or I eat to meet my vegetable intake, or whatever. I really seek to understand this complex role of food in our self, family, and community identity. And this exploration of meaning can unlock important insights for improving nutritional health and understanding why poor dietary choices persist despite widespread agreement that fruits and vegetables are more healthful, say, than a bag of chips. So these meaningful experiences that shape our relationship to food might be positive and some might be negative, but both are important. We'll talk in a minute about food trauma-informed approach specifically to food, but we do want to understand that when we're talking about a trauma-informed approach, it does not just mean talking about trauma. It also means about understanding positive experiences. So we don't just want to default to the adversity, because while these adverse experiences shapes our brains and bodies, the positive experiences are also a big factor in resilience and healing. And they're essential not just because they mitigate adversity, but because they are required for well-being and mental flourishing. So how do we celebrate positive experiences in our work instead of simply troubleshooting and problem solving? When we're using a trauma-informed approach, there's a process, and realizing that trauma affects our communities is the first step. The second step is then recognizing those signs of both trauma and resilience in our communities. Only then can we think about responding with trauma-informed practices, policies, and procedures. In order to resist re-traumatizing, we also have to be prepared to repair. So we need a plan for repairing and understanding resilience on a deep level, that it happens with support and care. And a strengths-based approach is a big part of this. And I know that you'll hear a lot more about that during the motivational interviewing section. So the first step is realize, right, in reframing these issues. And in our case, we're interested in reframing the relationship between dietary habits and weight. So we might used to be thinking, what's wrong with you? You know, what is the problem? Poor health, obesity, and what can we do to fix that problem? Instead, we might ask what happened to you instead, with curiosity and compassion. This might help us to understand the problem more fully, right? Several different scenarios might result in what we see before us. So poor dietary habits or poor health or overweight might stem from more than just a lack of education or compliance. In a trauma-informed approach, we don't consider specific events traumatic, but we understand that if bad things happen to people and they are not surrounded by love and support and protection, then it can be hard for bodies to recover from the stress. And trauma or toxic stress over time, which is often experienced as children, can cast a very long shadow. This means that something that happened when we're very young can have consequences throughout our entire lives. This is because when we're stressed and can't get back to normal, those stress hormones actually cause damage to our bodies. So we might think about trauma as having emotional impacts, but it's really a very physical process. And of course, one effect of trauma is this continued difficulty regulating, staying in balance and control of our emotions. This causes a lot of challenges, but it shows up especially in our dietary behaviors. So taking a more salutogenic approach, and I think they referred to this nicely in the Kitchenista video that we watched at the beginning, was how do we have a health-centered approach that asks something like, how is your ability to be well, build meaningful relationships, and live the life you want to live impacted by what has happened to you? Well, what are these adverse experiences or things that happen that could cause trauma? You know, and it's pretty broad. This is a commonly used diagram to show the three major categories of trauma: household, community, and environmental trauma. You know, some are loud traumas: abuse, neglect, an incarcerated family member. Some are quieter events: microaggressions, structural racism, difficulty climbing out of poverty. And these quiet events often occur regularly over time, leaving feelings of isolation and aloneness because they're quiet and because society does not always regard them as adversity. Well, how do you think these adverse experiences might relate to food? So some are explicitly food related, and I've circled them here. But what about some others? You know, for example, poor water quality might be linked to an increase in sugary beverages or an increase in food security because the cost of purchasing water and other beverages eats into the food budget. You know, further, it creates a fear of drinking water from the tap that might linger even when water is safe to drink. So some of that messaging about tap water might not resonate and might actually re-traumatize people who are listening to them. But food itself is routinely implicated in adverse experiences, right? It can be used to control and manipulate, or used inappropriately as reward or punishment. Anybody have a particular food that they were forced to eat as a child? Or a food that's associated with a particularly difficult memory? Even family meals, which are usually lauded as a terrific strategy for healthy eating and family unity, look a little bit different under the light of an abusive household. And weight bias, of course, is often passed down right at home before it's reinforced in other settings. And food security, even for brief periods, can have lifelong implications. I was once hosting a video screening on a food security documentary at a library in El Cajon during the debrief. We turn the lights on and this 88-year-old woman stands up, just tears streaming down her face, and painfully shared with the entire group the summer when she was 14 and her father had lost his job and their family was hungry. And she said that she never saw food the same way, that it just fundamentally changed her relationship. And it was a brief period. She said it was about 6 or 7 weeks when she was a teenager. So, even things like this feast or famine cycle that we see as a traumatic adaptation is sometimes hard to understand if the professional has not done some deep thinking about what it means to grow up in poverty with chronic resource instability. So clients who might burn through resources like food or money, making purchases that seem ill-advised to an outsider, and then are left with nothing at the end of the month, that may seem like, oh my goodness, if they just had some better budgeting strategies, not understanding that the root of that is just, maybe I just want to feel happy for a week before it's back to deprivation. I don't really trust the future. So this forward thinking budgeting doesn't necessarily, I don't really believe it, right? It doesn't resonate with me. Trauma is going to get in our way of being well, and the emerging science of the brain and body under acute stress and trauma helps us understand how our health and functioning can be impacted. So first, trauma is going to disrupt our brain and body wiring, making us more susceptible to heart disease, stroke, asthma, obesity, immune disease. And this is, of course, really regardless of risk behaviors. But the stress hormones that bathe our bodies during stress are like this faucet, right, that can't be turned off. And all that sort of hormone bath damages our bodies on a cellular level and affects all of our body's systems. So we can see how this system, all these systems are required to nourish ourselves every day. Right? A damaged nervous system, for example, can affect our ability to plan for meals in advance, to properly budget, to execute those very complicated tasks in the midst of stresses of everyday life. Damages to our endocrine system, and our metabolism, so that even when we're eating maybe recommended portions or a balance of foods, we might not see the same effect as an individual without trauma. And trauma is pervasive in our society, as we've talked about, and across income levels, but it is more of a concern in communities with high levels of poverty, racism, and environmental pollution, because some of those quiet traumas are more pervasive in there. Even some of the loud traumas are not as they're sort of more equally spread out. So coming out of that, then let's further refine our question that we might ask when we're considering a patient. How is your ability to manage your food resources, navigate the food environment, and effectively nourish yourself and others impacted by what has happened to you? How does this question reframe and kind of release the patient from needing to defend or feel judged? This is a little more of a tell me a story question. It also allows for positive answers. It allows for this both and. Someone could share that while they gained valuable budgeting skills from maybe a mom who was very frugal, but they're unable to put them to good use because of a partner who wants to celebrate every payday with a restaurant meal, leaving the family vulnerable to food insecurity at the end of the month. Lots of scenarios. How would you answer this question? How would you answer this questions at different times in your life, right? Maybe during your medical residency, for example, things look very different, than they do now for you. And I think subtle changes in how we ask questions allow us to uncover strengths and find evidence of resilience, instead of just assuming problems and looking to fill holes with solutions that could be irrelevant. So this way, when we do provide resources or support and the important information that we hold as professionals, we're doing so with a little bit more context. The takeaway here is that when it comes to health, especially nutritional health, adversity, trauma, and toxic stress can upend our plans for healthy practices. So this picture then does make logical sense when viewed through the lens of trauma and adversity, right? We may be seeking the biochemical regulation of food. When we're often out of balance emotionally, we're way more prone to those types of foods which provide immediate, if temporary, regulation like high fat, high sugar, high salt. Or maybe we learn different lessons about priorities and risks. Short-term considerations may be more important than long-term ones. And people may seek safety and control in foods that are familiar, consistent, and pleasurable. Right? That feeling of safety. I know what to expect here. And of course, adversity may mean that different people have different kinds of access, information, and resources that would enable them to make decisions around health and food. So when we do our big trainings, we collect a lot of data using a survey called the Meaning of Food and Life questionnaire, which is what you guys just did on the Mentimeter, just a little snippet of it. And this is some data that we've collected from primarily public health professionals. So at the very least, this data points to the reality that despite, say, getting satisfaction from eating health promoting foods, despite believing nourishing foods is a meaningful activity and getting comfort from those foods, we still report significantly lower scores when we're asked whether we actually eat in a way that brings us comfort, satisfaction, and meaning. You can see the bars on the left significantly lower than the 3 questions on the right. So trauma plays at least some role in this, although we would be remiss not to also come back to our modern food environment. And this is where we get into the continued relevance of social determinants of health, even if it's not the entire picture. This environment, including marketing and advertising, which is incidentally more pronounced in areas that have high rates of ACEs, really does feed the stress response. The modern food environment does not want you to put more tools in your regulation toolbox, right? The modern food environment says, yes, we're all you need. We can help you feel better immediately. It may not bring us long-term comfort, deep satisfaction, or meaningful relationships with food, but it does the trick in a pinch. When we think about a fully developed relationship with food, both trauma and the food environment we all live in leave most of us with some areas to improve. Of course, another way to look at nutrition is as a great foundation for generative conversations with patients and as part of our buffer against the stress that we know is there. So although trauma may complicate our quest to maintain a nourishing and nutrient-rich diet, a high-quality diet and well-developed relationship with food can actually prevent us from more trauma and help us heal. So trauma-informed nutrition security is a term that we use to highlight this complicated relationship between trauma, stress, food, nourishment, resilience, and the application of trauma-informed principles throughout the food system. We both acknowledge the impact of trauma, find strengths, and work to build resilience. Because resilience is both the capacity of individuals to navigate their way to resources, there is an individual component, but it's also our capacity collectively to negotiate for these resources. If we didn't have resilience, we wouldn't have a human society, right? We wouldn't exist as a species. We are designed to withstand assaults on our bodies and mind. It's not unlimited, but it is expansive. So collectively, this is something that we can handle. And resilience develops from experiencing positive things before, during, or after trauma or adversity. And there are many things that we know that can protect and heal, and every year we learn more. And so I'll let the motivational interviewing presentation kind of pick up here, but just knowing that you'll have an opportunity to dive further into protective factors and how this impacts your patient conversations. Going back to Dr. Folletti, right, which we heard about in our opening remarks, very important quote. The core finding of the ACEs experience was that obesity, whatever its health risks, is protective emotionally. And our more intractable public health problems, such as obesity, are often unconsciously attempted solutions to problems dating back to the earliest years. So even when individual behaviors contribute to the problem, those behaviors themselves may be rooted in the body's stress response. So how does this affect our theory of change? We started with energy balance, but maybe we go back further, right? And we say, well, maybe looking at where some of this stuff happens is from adversity and toxic stress, which then leads to both obesity and overweight and lifestyle diseases. So yes, they are correlated, but like the sun in that slide I showed a few slides ago, they are correlated, but not necessarily causative in every case. So from my experience as a nutrition educator, I have learned that clients are more responsive to my messages and can take steps towards wellness when I approach nutrition education differently. You know, how do we foster protection, resilience, and healing in our conversations and in our messages? How do we reduce stigma, shame, confusion, and tension? And sometimes that is by acknowledging it and shedding some sunlight on some of these things. How do we promote confidence, dignity, and joy in our conversations? How do patients leave feeling more empowered? And how do we inspire a compassionate and flexible relationship to our bodies, each other, and to food? And we've learned a lot over the decade and a half that we've been doing this work about what participants find most meaningful and engaging in our nutrition education workshops, right? And most of it was from observing and interacting, but we did do some very interesting focus groups in the summer of 2020 and really heard from people specifically around social media, kind of what they think. And some of this just may be helpful as you start to look at these issues in your own practice, but that youth look primarily to social media and the internet for health information. They also look to trusted peers and family members. They utilize social media for their emotional health, and they have a strong awareness of the role of stress and dietary health. So they all feel that their diet is impacted by their stress, but they don't have common strategies for how health could help manage stress. So that's an opportunity for you as providers to talk with young people about stress and how diet can help with stress. They didn't talk much about the role of providers in where they got information. So, they didn't say negative things, they just didn't say much. Adults, a little different. There was definitely a lot of distrust of mainstream sources among adults and a deep distrust of the medical establishment. We were primarily doing social media groups with people of color. But yet they did agree with most of the basic healthy lifestyle information. There wasn't any broad disagreement. And they acknowledged the link between stress and diet, but not nearly the extent that the young people did. So we do see that young people are much more articulate around stress and mental health than adults. So adults may need more help in drawing those connections. Okay, we're out of time. So I am just going to end here and say that the result of this is that prioritizing patient voices will really lead us to messages and interventions that people actually want and need. And these strengths-based conversations are a good place to start. But I do want to end with kind of this slide and just say, based on a lot of sociologists who study this as well as our information, food is more than just choosing the right things to take care of health or prevent obesity. Society and environmental factors outside our control are impacting my ability to do what's needed. And food insecurity, toxic stress, or daily stress makes things hard. And there is an unfair burden on mothers and women. And that autonomy and self-determination are important to me no matter what. And so acknowledging those things as providers and when you're talking to families can pave the way to a deeper, more empathetic, and hopefully more productive, conversation about weight and health that takes providers out of this anxious situation that they're in to solve people's problems for them or to make them feel shame, but instead asking generative questions that look for positive strengths to build on, I think can go a long way in reducing some of that stress. I'm starting to see some questions come in. So I think we have about 10 or 12 minutes left for some questions. I'll stop sharing my screen. Okay.
That was really amazing. I did want to ask one question, and then we'll go through to the chat and get some other questions. I think Jennifer and her team may be helping us with that. But I was wondering, because as you presented some of this, that TikTok video that you showed was really striking. And I think one of the things as pediatricians and providers, but whatever kind of healthcare provider you are, we don't always recognize how we come across. And so as you were going through your talk, I was wondering if you had any suggestions or had done any focus groups and gotten feedback from, the youth about how would they like us to ask about these questions, because the first Mentimeter showed that we're all afraid and nervous and we don't want to do this. So if you had any suggestions about how do we approach this topic, because this is not an easy topic to approach.
So what we've been doing is some trainings for providers, and I will go back to sharing, and this is one of the slides that I skipped, but let's go back. We had providers answer these questions for themselves, and it was pretty powerful. So we had them go into pairs, with Zoom, of course, and ask each other, I want to start by understanding how you might describe your healthiest and happiest self. Can you share with me what that means to you? And then asking the questions, can you think of a recent time when you were able to eat in a way that aligned with this idea of health? Like, what were you able to do and how did it feel? And then the third question, what made this possible? Like, did you receive support from others? Kind of what set you up for success? And the feedback that we got from providers, so this doesn't directly answer your question because we haven't directly asked these questions to youth, was that the providers went from saying, like, I was on the edge of my seat with curiosity listening to my partner answer these questions. I am never on the edge of my seat when I'm talking to patients. I have all these feels that you all expressed. So backing up from making those assumptions and saying what's going right and how can we build on that? Tell me from your experience, what's happening when it works, right? Things don't always work, but is there something that's working and what's happening at that time? What's making that possible? And how can I help you build on that success? Seems to be something that right now is really resonating with people as a potential way of introducing these, and not coming from this attitude of like, I need to quickly solve this person's problem in 45 seconds. And my brain is super busy because I'm taking notes, I'm thinking about my next patient, I'm behind already, plus not to mention I have a life. But how can I just be present with this person and listen? And it changed the emotional relationship and the emotional tenor of that conversation, quite a bit.
Yeah, thank you. Florence, did you want to go through the chat, or did Mary Moran asks a question here? Can you discuss the importance of sharing meals as a family?
Yeah, I mean, I think sharing meals as a family has a lot of research around it. And I think part of the reason is because it builds on those resilience factors of cultural identity, racial identity, making those social connections, even just having a nice, a nicely set table, draws us to that aesthetic experience. So we think about the different dimensions of our relationship with food, social, aesthetic, moral, cultural, whatever. A family meal when well done, or not, I mean, not to make it, can be good. I think the challenge sometimes is, like in my family, everybody has sports practice at different times, right? So I've seen family meals with my teenagers, kind of fall apart. So then it becomes, okay, breakfast, or maybe that before sports snack. Like, how do we be flexible and not just say, and the answer is family meals? It says, what about family meals makes it the answer, and how do we put those components into other times when we connect? Because, and as I think I mentioned on another slide, in an abusive household where there's a lot of drama and the family dynamic is negative, I would argue family meals maybe aren't always the panacea to that challenge, right? People may connect better one-on-one in some families than as a whole group around the table. Picky eaters have a really difficult time with family meals, right? And it can be a place of bullying and coercion. I remember I had one picky eater in my house, and when he was little, I decided, I am not going to let this kid ruin my dinner every night, so I'm just not going to care. Like, I will work it out, but I'm not going to make every family meal about being frustrated, with him. Yeah. Can you expand on function over form? How engaging in a healthy lifestyle allows their children to engage in social activities. Mary Beth, I'm not exactly super sure what you're asking, but I think there's a lot of like modeling that happens during those family meals that is passed down, right? How we talk about food, how we talk about health, how we share about our day, that allows, for sort of a positive cycle of things are articulated often during a family meal. And there's all just the body language and the care of having presented the meal.
Yeah, I also think family meals are a proxy for something else that we haven't quite measured. And there is a lot of other types of conversations, not just about food, that happen at the family meal.
Yeah.
And so, I think it's a proxy for other types of learning that, and so we're measuring it with the family meal, but there's something underneath that.
Yeah, it's a proxy, right? So we don't want to pretend it is the thing, but we want to explore it and understand it so that it can be replicated in other settings. Like we can get sort of more benefits out of the family meal, right, than just the family meal.
Yeah. Vanessa has a question here. I don't know, Vanessa, if you want to come off mute to ask your question, or if we can just read it as is.
Sure, I can ask it. Hi, Adrienne. Thank you so much for this amazing talk. I was just curious if you could elaborate a little bit on the adult focus groups that you did and on the distrust of the medical establishment, like if there were any main themes from the qualitative research that you did.
Yeah, it was pretty pervasive. I'll tell you that. Almost every focus group it came up, people just felt that the information that they were getting from the medical establishment was inconsistent. It was often changing. When you actually look at nutrition messaging, it hasn't changed that much, but the perception that it has is pervasive. Oh, sometimes they tell me not to do this. And when I was young, it was all about margarine. And now they're telling me not to eat margarine, eat butter. Like, wasn't supposed to eat eggs. Well, now I can eat eggs. I can't they're lying. They don't know what they're talking about. And so there was a lot of that. I think, things like Tuskegee came up. And so I think you just have so much racism. And I think African-American moms were very, very blunt in sharing with us how they did not think that they could be given good medical advice by many white providers. And so there was a lot of layers to it, but pretty much ran the gamut from surface level information changes to just deep historical racism and historical events that had caused probably irreparable trauma among some of those people in terms of their trust of the medical establishment. And, so it was really like a roller coaster of levels. And I just think a lot of lack of transparency, even just around getting medical care, getting mental health care, and just feeling overly burdened by a poor system meant that when they were having interactions, they just didn't really trust that it was about them. It was about getting through a day.
Yeah.
Thank you.
Mary, I noticed you expanded on your question. Do you want to also come off mute for a second, or
Adrienne, with my question of function over form, is engaging parents in a discussion about what would you like your child to be able to do? For example, walk up the stairs without being breathless, enjoy recess more, things like that. And that kind of approach to weight loss as a function rather than just how they look.
Oh, yeah. Thanks for clarifying that. I had the most powerful thing happen to me at Family Health Centers of San Diego many years ago when I was doing a nutrition class with their obesity clinic. And I had everybody do I thought I was actually considered adding the slide to this, but I had them do kind of a vision board, right, as a warm-up activity in the first session. And all these women were there, cutting out pictures of kale and skinny people doing yoga. And they were giving me exactly what I wanted, right, on this vision board. And there was this older gentleman, not even that much older, but he was an older dad. He had overweight issues, but also a heart condition. And he just took a marker, he made a mountain, and he put 2 stick figures at the top of the mountain. And he said, I want to be able to hike Cowles Mountain with my son. And it was sort of a mic drop moment to exactly your point. I am here because I want to hike Cowles Mountain with my son. And that's it. And it was very motivating for him because I think he did realize this is an experience, a relationship. This signifies so much more than just simply my doctor told me that I need to lose weight.
right?
But it was I'm owning the ability of what I want to be able to do with my life. And that goes to that empowerment and that self-directed behavior, as opposed to the medical establishment is telling me that my weight is making me sick. And the medical establishment wants me to get skinnier so that I'm less expensive to Medicaid, which is, I think, can be how people feel.
We have 1 minute left, and Christy has a really interesting question, but I'm going to skip to Annalea's question just because I think you can answer that in a minute. But I would love to have that conversation with Christy, maybe sometime later in the day. But any resources you would recommend for nutrition educators trying to deal with these issues?
Well, this is kind of what Leah's Pantry does. We do a lot of trauma-informed nutrition security trainings where we do a lot of self-care conversations, self-reflection, really getting not only WIC educators, SNAP-Ed educators, dietitians, medical professionals, everybody kind of in a space where they're allowed to they're allowed that space to explore their own feelings and understand things, and it's acknowledged. And so I think looking for trainings and opportunities like that, certainly it's possible to self-facilitate a lot of this stuff, creating space in your organization. So feel free to reach out to me directly. I don't know what my, Adrienne at leaspantry.org. I should put that somewhere. Someone put that in the chat, but yeah, I mean, this is kind of what we're trying to do at Leah's Pantry for our capacity building, exactly for that reason, because the people want it. They want to explore their own relationships so that they can do a better job providing community care.
Right. And as Jennifer said, we will be handing out some resources at the end. So your email will be in there.
Okay.